Welcome to the final installment in the Trends in Behavioral Health webinar series. This series is a collaboration between Epstein Becker Green, Nelson Hardiman, and the Behavioral Health Association of Providers. Today's webinar is titled, 1 in 3 Californians is a Medi-Cal beneficiary. Is your organization ready for the next steps in drug Medi-Cal's ODS waiver? Before we begin the presentation, please note that today's webinar is being recorded and participant phone lines will be placed on mute throughout the program. You're welcome to submit questions directly to the presenters during and after the webinar. Their contact information will also be displayed at the end of the presentation for your reference. In 2 to 3 business days, Epstein Becker Green will email all registrants a link to access a recording of today's program and PowerPoint materials. I'm pleased to welcome Kathryn Edgerton, a partner in Nelson Hardiman's Regulatory Compliance and Transactional Groups. We're also joined by Kevin Malone, an associate in Epstein Becker Green's Healthcare and Life Sciences practice. At this time, I'd like to turn the presentation over to Kevin.
Can you hear me?
Go ahead, Kevin.
Great. Awesome. Just want to make sure the audio is working. So thanks so much, everybody, for joining. And I want to thank Kathryn and her colleagues from Nelson Hardiman for continuing to participate with us. We can go to the next slide, David. David, do you mind advancing the slides?
Yep, I'm on background.
Okay. Great. So, just actually go back to the previous slide. Sorry, I thought that I was seeing the presentation, but I'm with you. Okay. So just to provide a quick overview of where we are and what we're going to be covering today, our goal really is to make sure that those of you who have sort of known about the ODS waiver in the background are sort of prepared for what the next steps are going to look like. We're going to provide a little background on what the ODS waiver is and sort of how it fits in the national context. We're going to talk a little bit about the details of the authority, go over the core elements and dig in a little bit different there into a little bit more detail. And then we'll talk about especially the different responsibilities that are unique to this waiver and that are really important for any organization that's interested in participating in the future. Then we'll wrap up with some next steps and some suggestions. So if we can move on to the background slide. Great. So just to put everything in context, I think everyone realizes that substance use disorder treatment services are an incredibly important part of the healthcare system in the United States. And Medicaid in particular is playing an increasingly important role as a payer for these services. For those of you who have been in the field for a while, you know that historically Medicaid was actually not the most important source of coverage for substance use disorder treatment services. However, through the Affordable Care Act and the sort of implementation since then, Medicaid continues to play a larger and larger role. A big part of this is that the Medicaid population, including the new adult group, have fairly high rates of substance use disorders. And it's a really important clinical condition among this population. As you can see here, just some basic data about how important this issue is, and that many people are seeking treatment, and the Medicaid program is an important source of coverage for that. If we can go to the federal landscape. So the ODS waiver in California sort of fits in, is part of a national initiative. And I think it's important to keep that in mind and sort of see how this fits into a broader policy initiative being led by CMS in Washington, in Baltimore, really. So to go back into history, in the summer of 2015, CMS announced a new opportunity for states to use the 1115 demonstration authority to launch projects for individuals with substance use disorders. And I think for those of you, for California, I think everyone can be very proud of the fact that California was not only the leader in this initiative and the first waiver to be awarded, But really, like, as a former CMS official myself and being privy to some of those conversations, without California's pressure and ongoing support for this program, it never would have come to fruition. And what it does, as sort of a basic matter, is that it allows states to cover the residential addiction treatment services, but that have always been excluded from Medicaid coverage under the IMD exclusion. And for those of you who are not familiar with the IMD exclusion, it has been in place since the implementation of the Medicaid program, and really reflects the fact that when Medicaid was created, there already was a large system of state and county and locality financed psychiatric hospitals and institutional behavioral health care in general. And the federal government didn't want to sort of step into and supplant that sort of existing budget and operational system, and wanted to make sure that there wasn't an incentive for states and counties and localities to cut off the funding for those programs and try to shift all of that onto the federal government. In addition, it fed into the sort of broader strategy around community integration and deinstitutionalization. However, there's been growing pressure over the last decade to think about it differently. Everyone understands that both the IMD exclusion as it applies to substance use disorder services and psychiatric, residential, and inpatient care has not necessarily corresponded with the investments in community-based services that everyone thinks is necessary, as well as in supportive housing and other affordable housing options. And it's really sort of dovetailed with mass incarceration. And so in light of that, there's been incremental developments at CMS in thinking about how, in certain contexts, they will start allowing Medicaid reimbursement for individuals that are served in what has historically been IMDs. The 1115 initiative, including the one in California, is really the first step around substance use disorder residential treatment in that regard. However, there's a big catch that CMS built into the 1115 program around residential addiction treatment, and that is super important to our presentation today, which is that in return for being able to cover residential addiction treatment services, states are obligated to undergo a comprehensive redesign of their substance use disorder treatment system, obviously driven by and built around the Medicaid benefit and reimbursement system, but that needs to establish a comprehensive continuum of care that is based on independent evidence-based standard. And we'll talk a little bit about what that standard is in a minute, and sort of what that means for all of you. So if we can move on to the national landscape, next slide with the map, you can see that since California, there has been a expanding wave of states. So the original 1115 opportunity from 2015 included really a commitment and limitation from the White House Office of Management and Budget that only 5 or 6 states were going to be allowed to use this opportunity at the outset. However, the experience in California already and in other sort of first wave states really led to the perspective within the administration, both the Obama administration, now the Trump administration, and on Capitol Hill, that this is a great opportunity and it's an important initiative that should be made more broadly available. And so subsequently, CMS has amended and re-released their initial announcement about the 1115 program and has opened it up to any state. In addition, the opioid legislation that Congress passed in this session is one of the sort of key provisions is that it will make it even easier in the future for states to provide coverage for this level of care within broadly the same construct around broad, comprehensive continuum redesign, using hopefully a state plan amendment process rather than 1115. And so, this map indicates that you see that since California opened the door, really states across the country, including in some of the Mid-Atlantic and Appalachian states where the opioid epidemic has been most devastating, that you see that really California's leadership has led to transformational change in the coverage of a full continuum of care, including residential addiction treatment, under the Medicaid program across the country. And so I think it's helpful to have that context as we think about ODS in particular, that this is really a part of a national movement that is transforming the face of addiction treatment services in the country. So moving on to the ODS Waiver Authority, it's, as we discussed, it's a pilot program demonstrating how care increases, increased access to substance disorder treatment can decrease other health system costs, and that's tied to really the 1115 Waiver Authority, which in its terms requires states to demonstrate savings as a part of the pilot, and in order to have the authority to offer new benefits. And so, we've discussed that one of the elements is the full continuum of care. And when CMS first announced it, they really strongly, they actually required states to use the American Society of Addiction Medicine ASAM criteria as the sort of clinical and infrastructure for that continuum of services. They have since revised that to just allow states to use an evidence-based continuum of care, and ASAM is identified as one example of that. In addition, the California Specific Initiative involves some really interesting and unique approaches around local control and accountability, which obviously builds on the legacy of county-led delivery systems in California. There's also new initiatives around utilization control and oversight around provider contracting, which we'll get into a little bit later. And more intense sort of program oversight and integrity sort of statewide. Also, there's a strong effort around increasing the access of services for individuals with criminal justice system engagement. This is something that states across the country are making a big push on right now. States like Rhode Island are providing medication-assisted treatment with a 12-month follow-up for everybody in their entire jail and prison system. And who obviously is screened for and needs that level of care. And states across the country are looking at these things, and ODS is a part of that as well. So we're sort of halfway through the 5-year process, and it really will be elective during that process, and then we're getting ready for a period of time in the future when the ODS program will become mandatory. So it's really great timing for us to have this conversation, because for those of you who are fully experienced in it, you likely will have a lot to contribute to to the perspective of your peers. But it also is a time for those who have not experienced ODS or participated in it so far to start getting ready, because unless there is some sort of change from CMS or California statewide leadership, it is coming. So moving on to sort of the core elements on the benefits, just want to touch on this very quickly, and Kathryn's going to speak to this a little bit more later, but you can see that in comparison to the standard benefits that are currently available in all counties, one of the sort of most important elements of the ODS waiver is that there are a significant expansion of services available in the pilot counties. And if we move on to the next slide, I want to talk about sort of two benefits in particular, starting with residential addiction treatment. So residential is, as we discussed from the outset, really sort of the core of the entire 1115 initiative nationwide. And residential has historically been not only excluded, but the way the IMD exclusion works is actually much more broad than people generally know, which is that if an individual is being served in an IMD, they're not actually eligible for, well, the state is not eligible for federal match for Medicaid services provided to that person, even if they're outside of the IMD. So meaning if someone was in a residential addiction treatment center that is an IMD historically, that individual not only the services for the residential addiction treatment wouldn't be covered, but any other Medicaid services to that individual, like even hospital services, would not be reimbursed. So it's a really, really big deal to expand and in fact waive the IMD exclusion for individuals in these levels of care. So the residential benefit, as you can see, has historically been extremely limited and really only to individuals that are in residential treatment settings that are not IMDs, or there's two populations that are not subject to the IMD exclusion. One is young adults and children and Medicare beneficiaries, and that's really has been the full extent of the residential addiction treatment benefit, which if you step back really means that from the state's benefit perspective, they have not been able to offer a full continuum of evidence-based addiction treatment services to Medicaid beneficiaries in the state. And so now there will be no bed capacity limit in pilot counties, and providers who meet the ASAN treatment criteria, which both Kathryn and I will talk about a little bit more later, are able to participate in Medicaid for the first time. Counties are required to engage in the prior authorization of these services, which we'll talk about that in more detail in a minute. So moving on to the next slide around medication-assisted treatment. This is the other, what I would say, sort of big sort of prong of the ODS waiver with regards to the provision of new and expanded services. And I think this is an area where I would anticipate even more change in the coming year following the passage of the comprehensive opioid legislation in Congress. And so the sort of traditional services were fairly limited with regards to the coverage of medication-assisted treatment. And under the ODS, there's sort of additional medication-assisted treatment services that significantly expand access to MAT. And in addition to, I think it's important to keep in mind that expanding access to medication-assisted treatment is probably the biggest trend in national substance use disorder coverage and payment policy in the country right now. It's an extremely big deal that states across the country are trying to figure out how they can support in a variety of different ways the expansion of MAT. And the ODS waiver is a really important way to do that. I would add that the opioid legislation passed on Capitol Hill makes it sort of incrementally easier for physicians and non-physician prescribers to receive the waiver necessary to provide to prescribe non-methadone, buprenorphine, naloxone, and other sort of non-methadone modalities of medication-assisted treatment. And there are other sort of incremental changes in that legislation that will hopefully, I presume, will be rolled out in California through ODS very soon. So moving on now to sort of the eligibility-related elements of the ODS program. You can see that there's no age restrictions for the program. Really, it just requires that the individual be enrolled in Medi-Cal, reside in a participating county, and meet medical necessity criteria. And this is an important element that the counties are dealing with right now. We're going to talk a little bit more about that in a minute. But the sort of adult and child assessment-related activity and the way counties and providers are engaging in that assessment and level of care placement documentation is definitely something that is a work in progress, and is definitely something to look into and talk about more in a minute when I talk about county responsibilities. So counties, as we discussed, move on to our chart of county responsibilities in this sort of honeycomb picture here. You can see that under the ODS program, counties are taking on a broad array of significant implementation responsibilities. You know, they're responsible for beneficiary protections. They're doing provider contracting, including, you know, residential authorization. They're doing quality assessment of providers and performance improvement. They're responsible for a lot of the care coordination across the primary care and behavioral health continuum. And so if you move on to the managed care, county responsibilities managed care tab, slide, you can see that really the biggest change here is that counties are not just acting as sort of their traditional role. ODS is requiring them to serve as a full-on managed care organization under federal law. And that means that they're subject to 42 CFR 438 and state contracting law requirements, which is a new responsibility. You know, they are, they're doing things that health plans are normally doing. You know, the experience that we've seen so far, well, I'll actually come back to the experience that we've seen so far, but I think it's important to realize that as this program rolls out, if you're a provider in these counties, that you need to sort of prepare yourself and work on and make sure that you have a strong relationship with the county programs that are going to be implementing ODS. So moving on to discussing the requirements for county responsibilities, I think just to touch quickly on, to dig in a little bit deeply, we prepped this around ASAM a little bit earlier, but one of the key requirements is that counties are required to use a benefit design modeled on the ASAM criteria, covering the full continuum of substance use disorder treatment and support services required by those standards. So for those of you who are not familiar, the ASAM criteria really is probably the most well-known national set of evidence-based clinical standards defining both the assessment and placement criteria for individual patients, what historically was called the ASAM patient placement criteria, as well as defining the staffing and clinical model that needs to be used at each of those levels. And so what counties are doing now is trying to deploy the ASAM criteria in their in the process of overseeing and managing a network of providers. And this is very important. You know, the way California is currently doing this, and this may change in the future, is that they are requiring providers to self-attest to meeting the ASAM level, the ASAM criteria standards for a specific level of care that they're purporting to offer. And this is challenging. And I can say that we've seen some announcement recently that ASAM is rolling out a number of level of care certification programs in partnership with CARF, as well as some training programs to help ensure that providers that are attesting to meeting certain levels of care actually have an independent assessment and justification for making that assertion. And that's definitely something that providers that are participating in ODS and attesting to meeting ASAM level of care pay attention to and prepare to participate in if they can in the future. So moving on to county responsibilities around access, the counties are responsible for making sure that patients that members now in their in the ODS program in their county have access to all of the full continuum of services now covered under the waiver. And it's very important to note that this isn't just a sort of a hypothetical obligation. The federal managed care regulations 42 CFR 438 now apply to county operations in this regard. And there are, substantive requirements around timely access, cultural competency, oversight, provider selection, and contracting policies and procedures that provides a pretty formal and strict framework for county operations in ensuring access. And if you move on to the next slide, we can talk really about what that means from a network adequacy perspective. And this, as we're going to talk about in a minute, is one of the big areas of challenges that counties have been having in making sure that they have comprehensive network adequacy across the continuum of services covered under the waiver. And so, counties are required to develop timely access standards. They have to include emergency and crisis care. They have to build this model of network adequacy using the anticipated number of eligible clients and the projected utilization of services to make sure that they have a number and type of providers across the continuum. And for those of you who have dealt with the network adequacy criteria standards that are utilized in the Medicare Advantage program, it's very similar, where you have, for each benefit and provider type, there's a formula that has to be used to identify how many providers are needed to be under contract. And a really important point is a full geographic analysis. And this is a big deal. This is a new and a significant responsibility for counties. And for counties that have not done this before, it's definitely been, I would say, a learning experience from what we've been reading and seeing. So moving on to selection criteria. This is an important perspective for providers to keep in mind. We've discussed a little bit already about the ASAM criteria, but there are other participation requirements that if you're in a county that is going to be participating soon, you should start looking at these criteria and thinking about it, in addition to some of the ASAM criteria stuff that we're discussing. So there are obviously licensing and certification requirements. There's enrollment with the HCS directly as a provider. You have to have certain staffing with regards to a medical director. In addition, there's going to be new requirements around cultural competency, including translation services, and your ability to coordinate care for those enrollees receiving medication-assisted treatment with the prescriber if you are not the prescriber yourself. And in addition to the ASAM criteria-related expectations around the model of care, there's new evidence-based practice requirement that counties are going to be ensuring that any provider implements at least 2 of the following evidence-based practices. And that includes motivational interviewing, CBT, relapse prevention, trauma-informed treatment, or psychoeducation. And there's a lot more guidance on all of these requirements from DHCS. So finally, on county responsibilities is another sort of big thorny issue that's important for providers to keep in mind, which is contract appeals. So I think providers should realize that one of the advantages from your perspective of having the counties be subject to 42 CFR 438 is that contracting arrangement is subject to federal regulation through the state. And that includes some protections for providers around that contracting process. So if a county denies your effort to be under contract, they have to follow certain procedures, including provide a written notification, have a protest and an appeals process, including an appeal to the state. And so it's important to have those in mind as you start thinking about the contracting process going forward. And if you're already under contract and you're having some issues with the county contract, remembering that you have access to some of these rights and protections is important to keep in mind. So we've discussed county responsibilities. It's important to touch quickly on the state. So obviously the state does have significant oversight requirements. These are similar to what you would see in state oversight of commercial managed care contracts in general. So if you see you've got monitoring plans, triennial reviews, reporting of activities, and they're, most importantly for providers, the state is actually overseeing the ASAM designation process for residential addiction treatment providers. So it's important to keep in mind that if you are a residential provider and you're contemplating participating in ODS, which I encourage you to do so, if it makes sense for you from a business perspective, is to keep in mind that you're going to have that sort of state oversight with regards to your attestation of meeting the ASAM criteria with regards to residential. In addition, moving on to state responsibilities, they have a lot of sort of fiscal related responsibilities. There's development of the reimbursement rates that counties are going to then be using, which providers sort of in general tend to spend much time thinking about managed care rate setting, but I always really encourage providers to become knowledgeable about this because there are many ways in which providers indirectly are sort of impacted by the way in which states set managed care capitation payments to to counties in the ODS context or in others, and it has a big impact on the way in which that plan engages in rate negotiations with you, and so it's important to realize that the state is engaged in that discussion with counties right now, and that's definitely something to pay attention to as this gets rolled out in your locality. In addition, the state is responsible for overseeing the way counties comply with 42 CFR 438. As we've discussed before, the counties are now subject to all of these new federal requirements. The state is actually the primary entity responsible for that oversight. So if we move on to rates, obviously I touched on this quickly. This gives you a little bit more background on what goes into that, and it's important to sort of be aware of what it is that the state is going to be using, and that a big part of that is looking into a differentiation between residential and outpatient rates, that they're looking at sources of data, looking at inflation factors, detailed provider and indirect service cost estimates, and you can see how relatively quickly the way you're providing data and interacting with the county and it has an impact upstream for the way in which those reimbursement rates play out. And so now moving on to the overview of the pilot programs, and I believe I may be turning things over to Kathryn. Is that right?
Yes, thank you. That was very informative, Kevin. So now we are going to give you an overview of California's pilot programs and a few of the lessons learned from these programs. So as background, in California, 8.5% of residents aged 12 and older, which is 2.7 million people, met the criteria for having a substance use disorder in the past year. However, only 1 in 10 received treatment. So the ultimate goal of the pilot programs is to treat more people more effectively by reorganizing the delivery system for substance use disorder treatment in Medi-Cal. You can move on to slide 26. The Drug Medi-Cal Organized Delivery System is the nation's first substance use disorder treatment demonstration project, as mentioned by Kevin. 40 California counties are taking part in the pilot program, which was approved in 2015 and will run through 2020. As of July 2018, 19 counties were providing services under the pilot, and that represented approximately 75% of the state's Medi-Cal population. Move on to slide 27. When the remaining 21 counties that have submitted implementation plans begin services, then over 97% of Medi-Cal enrollees will have access to the pilot programs. And finally, the tribal and urban Indian health programs are scheduled to begin implementation in the summer of 2019. Moving on to slide 28. And I'm just saying this because I don't actually have access to see what the slides right now, so thank you for bearing with me. Historically, substance use disorder treatment has been associated more with criminal justice than healthcare. And according to the California Healthcare Foundation, the counties that they interviewed estimated that prior to the implementation of the pilot program, at least 1/3 of substance use disorder treatment services delivered by the county system were actually mandated by courts as part of sentences for drug-related offenses. Under the pilot program, substance use disorder treatment has been brought more into the larger healthcare landscape, and addiction is being reframed as a chronic disease, which is a fundamental shift. Slide 29. Prior to the pilot program, and in counties not participating in it, the standard drug Medi-Cal program covered a limited set of services. It covered services primarily included outpatient counseling and methadone maintenance. And Kevin mentioned this a little bit before. So the ODS pilot program provides all of the services that were provided under the standard drug Medi-Cal program, plus a bunch of other services, including multiple levels of residential substance use disorder treatment, case management, which is very important, expanded narcotic treatment programs, withdrawal management, recovery services, physician consultation, partial hospitalization, and additional medication-assisted treatment, which Kevin touched on earlier. Under the pilot program, participating counties serve as managed care plans and have the authority to contract directly with qualified service providers to deliver care pursuant to county direction. Slide 30. So let's talk a little bit about some of the keys to success. According to the study conducted by the California Healthcare Foundation, the main keys to success are provider engagement, ongoing communication plans, and creative partnerships. So one good example of provider engagement is Los Angeles County, where they gave providers policy guidance and held regular public meetings on provider requirements, training, billing, and claims processes, so the community was prepared. An ongoing communications plan is also one of the keys to success. It is important that there is a clear and consistent communications plan about the pilot program so that other county agencies, such as the criminal justice system, and such as other county agencies, the criminal justice system, providers, health plans, and others are aware and supportive of the program. And then finally, creative partnerships are important. The California Healthcare Foundation gave an example of Riverside County, which partnered with a hospital's neonatal unit to connect new mothers whose babies had fetal exposure to substances to treatment services through the pilot program. So let's go to slide 31. Now we can discuss a few of the challenges. Based on the California Healthcare Foundation's interviews with the counties, they identified a few major challenges. The first is the issue of stigma. There's still misconceptions about substance use disorders and its treatment, and people view substance use disorders as a personal failing sometimes and not as an actual medical condition. However, we have seen that the public attitude on substance use disorders is evolving and shifting. Slide 32. Another big challenge is the interaction with the criminal justice system. So obviously all individuals have unique needs, and court-ordered treatment may not meet those unique needs, or court-ordered treatment may not meet the requirements of medical necessity. Slide 33. The third major challenge is dealing with administrative structure requirements. So there are much increased requirements for documentation, training, and coordination of care. And providers have to front these startup costs necessary to meet these increased requirements and to deliver care under the pilot program. And these additional expenses, include things like hiring new staff, new technology, facility improvements, and new training programs. Next slide, slide 34. The fourth big challenge is also a supply and demand issue. There is a need for a sufficient supply of qualified providers, and there's very high demand for services. So more residential providers are needed, and more providers who serve the youth population are also needed. Slide 35. Finally, predicting costs and budgeting is difficult for the counties. So better budgetary planning is going to be needed. The increased demand makes it harder for the counties to predict the cost of services that will be needed over time. And then slide 36. So despite all of these challenges, the pilot programs offer a huge opportunity. John Connolly, the individual leading the implementation of the Los Angeles County pilot program, said, "This is a generational opportunity to advance SUD treatment. Everyone, providers, patients, and plans should realize how important this is. It's a watershed moment for Medi-Cal." So, you know, even though there are challenges, we have an optimistic outlook on these pilot programs. And Kevin, I don't know if you have anything more that you would like to add in addition.
No, thank you very much, Kathryn. I think it's very helpful for folks to see sort of where, you know, there's some really great resources that have been developed both by the state's evaluation contractor and some of the, you know, the California Healthcare Foundation, identifying the experiences that counties and providers have had so far. And if you're in one of those counties, then it'd be, I think, very useful for folks to take a look at those. And if you're in a county that hasn't participated in ODS yet, they're particularly important so that you can start preparing and getting ready for ODS coming to your area.
So, Kathryn and Kevin, there are no questions at the moment. Do feel free to submit any questions through the WebEx platform. But while we wait for folks to do that, Kevin, I'm wondering if you have any common questions that you generally receive on this topic.
Sure. Yeah, I think that, you know, one of the things that I do get some questions about is the level of care assessment. And, you know, there are, you know, I think it's, you know, doing a comprehensive level of care assessment in compliance with the ASAM criteria is, in a way that sort of really reflects the substance of those standards is technically very difficult. And, you know, I encourage providers that are interested in making sure that they're doing it in a good way to look into the ASAM Continuum product. Full disclosure, I do represent ASAM in a number of matters. Just want to make sure that folks know that. But I think it is an incredible product, and I do know that it's really the most effective way of deploying the sort of patient assessment and level of care placement elements of the ASAM criteria. And I would anticipate that going forward, there's going to be more oversight into the process by which counties are assessing the medical necessity of a given provider's, you know, placement of a patient at a certain level of care in the new continuum. And the ASAM criteria continuum product is really a great way to do that in a way that's integrated into the electronic medical record. It's really a robust tool that can be used to make sure you do those assessments in an evidence-based manner.
Kathryn, a question just came in. How do you become a participant in the ODS program in LA County? Could you help answer that? Are you there, Kathryn? Okay.
This is Kevin. I can respond to that as well.
Great.
So there's some information on the LA County website about how to contract in the ODS program. So I would they have, you know, like one of the requirements, you know, some of the elements that grew from their being, you know, required to operate as a managed care organization under 42 CFR 438 is that the county has a process for receiving sort of requests to become a network provider. So I recommend going to LA County's sort of ODS specific website I'm trying to look up what that actual URL is right now. Yeah, so it's under, if you just actually search for LA County ODS, you'll be able to find their website. It's publichealth.lacounty.gov, and they have information there about the process. There's some provider meetings, and there's a bunch of information there on the website, and a bunch of announcements, training, and other resources in order to try to participate in LA County.
Thanks, Kevin. Another question that just came in. We currently have SUD residential tax benefit in our Medicaid population, but we are finding that residential treatment facilities are discharging members after 28 days of treatment with zero follow-up post-residential. There seems to be a major lack of FU post-residential. Any suggestions for this?
Sure. Yeah, I think that I really encourage folks, and Kathryn may have her own suggestions as well, but I really encourage folks to connect with the county on those issues. Right, the county is now responsible for ensuring access to the continuum of care, and if there's a breakdown in the sort of post-residential transition, that's obviously a major risk area for patients. Residential is an evidence-based modality, obviously, but the ASAM criteria provides some pretty clear standards for the transition process from one level to the other, and it's a complex and high-risk transition process. And if you are seeing problems there, it might be sort of relating to, some of the network adequacy and other issues that we, indicated the counties that Kathryn spoke about, the counties are running into. So I think it's the first step that I would do is reach out to some of the care coordination staff at the county, and then, if there's sort of more detailed, potentially legal-related questions and support, we're available to have a longer conversation about it if we can be helpful.
Excellent. Thanks, Kevin. That seems to be all of the questions that have come in. I thank Kathryn and Kevin for their time and joining us today. That concludes today's webinar. A reminder that in 2 to 3 business days, Epstein Becker Green will email registrants a link to access a recording of the presentation and PowerPoint materials. Thank you for attending.